Miriam Sanchez, and I'm going to present a unique case of median arcuate ligament syndrome, anorexia nervosa complicated by gastric ischemia. I wanted to start by giving a brief introduction before presenting our case. Median arcuate ligament syndrome is caused by the compression of the celiac artery by the median arcuate ligament of the diaphragm. It usually presents with abdominal pain that worsens after meals. Patients may also develop a fear of food. This is a rare diagnosis, found in 2 out of 100,000 patients. MALS as a complication of anorexia nervosa has only been reported twice. However, necrotic ulceration induced by MALS is even rarer, with our case being the first one reported in a patient with anorexia. In terms of case presentation, our patient is a 39-year-old woman who presented with moderate intermittent generalized abdominal pain of 1 week duration, associated with nausea and non-bloody diarrhea. She described the pain as a mixed, dull, and sharp alternating sensation triggered by food intake. She denied taking any laxatives prior to admission. She had experienced similar but less intense episodes in the past, all of them alleviated by inducing vomiting. Her past medical history noted for schizoaffective disorder and anorexia nervosa of the Porgin subtype. She was known for multiple previous hospital admissions due to electrolyte imbalances and suicide attempts. Physical examination demonstrated a cachectic woman with a blood pressure of 92/49 and a heart rate of 156. Her body mass index was 12.21, weighing 64 pounds. The patient was admitted to ICU for septic shock. On her third day of hospitalization, she experienced melena emesis and her hemoglobin level dropped to 5.1. An EGD was performed, which revealed localized severe mucosal changes characterized by necrotic ulceration entirely on the graded curvature of the stomach. Due to findings suggestive of ischemic enterocolitis, a CTA of the abdomen was performed. The results revealed an 80% stenosis of the proximal celiac trunk, while the gastroduodenal artery and superior mesenteric artery appear unremarkable. Conservative management was performed, which included volume restoration. Neither surgical nor endovascular interventional procedures were carried out as the stenosis was extraluminal. Total parenteral nutrition was initiated, anticipating as a need for a prolonged and indefinite period. Fortunately, the patient showed significant clinical improvement soon after starting treatment. The previously described portal venous gas and pneumatosis resolved 3 days after fluid resuscitation. An EGD conducted 4 weeks after discharge documented the resolution of ischemic gastritis. Also, during her 3-month follow-up visit, she reported significant weight gain of 48 pounds with a BMI of 19.96, weighing 112 pounds. During this visit, the patient reported being able to consume 75% of her meals. Talking about possible differentials, superior mesenteric artery syndrome, which has been reported as a complication causing gastric ischemia in patients with anorexia, was ruled out in our patient by a patent SMA and no duodenal compression. What I like about this case and the reason I chose to present this case is not only because of its uniqueness, but because it's also meaningful. I picked this case because I wanted to create awareness that patients should always be evaluated holistically, regardless of how many times they present with similar symptoms. While a patient was initially labeled as having an eating disorder, there was an underlying condition potentially causing her fear of eating and relief from anxiety after vomiting. I want to believe that all of us are here today because we want to change lives. Our case is an example of how we can change lives one patient at a time.